Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hi everybody, we are the Millennial Mechanical Therapists. I'm Joe.
And I'm Clay.
And today we're going to talk about why does everyone have to be right? We do, if you've been following us, which you'd be watching this if you've been following us, or if this is your first time, look back at some other videos. But if you follow us, you've seen that, one, we practice pretty heavily using the mechanical diagnosis and therapy assessment with pretty much any patient that we can. And not that we don't use other techniques and other types of thought processes, but if the patient at hand falls into a classification syndrome that makes sense, we progress forward. But there's other ways to treat patients. There's other assessment processes and thought processes out there. I mean, there's a lot in our field. That could be a problem.
Yeah.
I think that's a little bit of a problem because I think you unfortunately get too much variety.
Mm-hmm.
But we're going to talk about, why does everyone necessarily have to be right on how they think? And does it even matter if you're right? Disclaimer before we even get into the talk, we're not saying that research and what research supports and any evidence-based research and clinical practice is not good and that you should disregard that because you should just do whatever you want. But, right now, the research out there that we have doesn't really support much of what we do. There's only a few things that have even a decent amount of research on them to be even considered, reliable and valuable. And even that isn't great research.
And the funny thing is none of them are approach specific necessarily.
Oh yeah, no, it's very general information.
So, the point that we're getting down to in terms of the nuts and bolts here is just that in the beginning everybody is kind of having this big old pissing contest about, I know more about the body in terms of anatomy, and I know that this ligament's going this way or this tendon's rubbing over this bone, and that's why your pain's a problem. And anytime somebody would come in and challenge that notion, well, they're obviously wrong, obviously. And then all of a sudden we're getting into a realm now where the pathoanatomic diagnoses are maybe a little bit more, we're more skeptical because of some of the research. And again, that's not what we have a contest with, but we're kind of going back into that cycle now where everybody's going, you can't use pathoanatomics, you can't use biomechanics. Those are wrong. And yeah, some of the research backs that if you mobilize a shoulder anterior or posterior, it's still going to move farther. Okay, yeah. Well, we can't just, what's that saying? Throw the baby out with the bathwater? Yeah.
Yeah.
That's pretty much what's happening all over. And it's like, well, yeah, none of these things on your x-ray matter because it's all in your head. Okay.
That's pretty hard sell.
Yeah, I mean, your pain's here, but it's all here. Like how we kind of get into this thing where it's like, well, no, that you're wrong because it's all pain science, or you're wrong because it's all
biomechanics
or
this
whatever
person versus that person.
Why does it have to be one thing?
Yeah. No, I agree.
So,
I mean, what's the point? What is truly, I think we've strayed away from the fact that the school of thoughts, whether it's using MDT or a pure biomechanical approach, or even more of just a any pure approach, regardless, it's a thought process. It should be an assessment process. If you're going to go and do something, you should have something that allows you to assess the individual, not just treat them blindly, but assess them and then reassess them and assess them again to ensure that whatever you're doing with that patient, whether that's just education or some sort of manual technique, that it's making a change for that individual. I mean, hopefully a lasting one, because they come to see you because they're in pain and because they want to know how to help themselves, not because they just want X, Y, and Z thrown at them. So, but does it truly matter? I mean, the patient doesn't know what Maitland means, or what who Kettleborn is, or, you know, who Lorimer Mosley is and what he does. The patient has no idea what that is. The patient doesn't care. The patient cares because they're coming in because their shoulder freaking hurts and they want it better, really. And we're drifting into more of a consumer market. And sooner or later, when people are purely paying for their research or for their treatments, then they're going to go to people who make sense to them. And I mean, if you can't get down on the patient's level just because you're so wrapped up in your belief, that's not a part of evidence-based practice. I mean, patient's belief is a part of evidence-based practice.
Yeah.
So you got to kind of come down, and that's tough. That can be humbling. I mean, that can be quite not nerve-wracking or upsetting, but that can be quite challenging for the therapist who really wants to be evidence-based practice, wants to do everything he can do to better his patients, but sometimes you have to take a step back.
That's a huge paradigm shift. I mean, especially going through school, I think you can relate to it too. Doing manual therapy, doing manipulations, doing things like that, it's cool. It's just like, it's glamorous, and it's lack of a better word, it's cool, and that's interesting to people. I mean, that's probably one of the reasons why that has been so successful, is because people come in and they pay the money to get a lot of this hard work from somebody using their hands, and you can kind of justify that I'm doing a whole lot. And recently we're kind of backing off of that, and we're doing a lot more in terms of the education-based just interventions. So whether it's pain science or patient empowerment through exercise programs, whatever it is, it's a lot more hands-off in a way. But as we go through that, we don't have to have one that's better. We just have to have one that works. And again, some of the research shows a few things work. They work better than other things. But nothing has to be right. And we don't have to keep infighting with each other to prove that one's better and one's not better and this and that. Because we're just going to end up in the bottom anyway. We're going to kind of lose sight of what we're trying to do, which is make people better by defending what we think is right. And that's one of the big reasons why we always say that we heavily practice MDT, but the real point of all of our videos is just to show everybody what we do and kind of just give it the point that we try to make a lot of empowerment to our patients and really just take attention to everything that they're doing. So whether you call it McKenzie, you call it Maitland, you call it biopsychosocial, you call it whatever you want, if you really just get into it, it seems like that seems to be more of the point rather than saying I'm right.
Yeah, no, I agree. I think it doesn't matter how you think, as long as you have an ability to think through. You know, because there's a lot of therapists out there who aren't consistently showing up each day and each individual patient. They're assessing, reassessing, making sure that whatever intervention they apply is making a change. I mean, we know natural history of a lot of these types of things. Natural history of elbow pain is 2 months. Same thing with low back pain.
Yeah.
If you can't help that individual before that happens, did your intervention count? I mean, did your intervention do anything? I mean, can you honestly say that it did if it took you just as long as the natural progression of an episode can last? So, I mean, these are things that we have to take, responsibility for and face. So I think regardless of what you do it well and get really good at it. And it's okay. There's always shortcomings in everything. I mean, acknowledge that, but get good at whatever makes your mind, allows you to think through problems and situations and get good at that. And then once you're good at that, see, where are your areas? Where can't you treat people because of the shortcomings in that, and then find something to help you think through that. And I think doing that, regardless of whatever it may be, as long as you're using some of the evidence to back up what you're doing, not obviously just blindly following something because it looks cool or sounds fun, will allow you to really be a good practitioner and keep your patients coming. So I mean, no, I agree with you. It's just it seems very weird. We're as a profession who really tries to pronounce that we are close knit, tight, that we're all about supporting people and helping people. We have like turf wars like crazy, and it's understandable because there's it's tough when some train of thought says one thing, the other train of thought says another thing, and they kind of conflict, but yet both people tend to get good results.
Good outcomes. Yeah.
I mean, that's tough, right? So who can say what? Does there really matter at the end of the day?
Yeah. A lot of times I think we have to change the argument from who was right to does it help. So does it matter if either of them is, if you use a biomechanical approach and you get somebody better in 4 visits, or if you use a pain science approach and you see them 4 visits, is one right? They both helped. So
patients both happy at the end of the day. That's really the end goal. So
we just want to throw that one out there, guys, and see kind of what your thoughts are. Leave us some comments on Facebook, YouTube, anything like that.
Yeah,
message
let us
us.
know. This is a good topic. I think it's something that many people are out there thinking about, especially if you're seeing this on social media. So check it out. Find us, at our website, like Clay said, Facebook and YouTube, and leave some comments. We'd love to hear what you think. As we say at the end of every video, move your patients early,
move them often,
and move them to end range, my friends, because that's where the magic happens. See you next time.
See you guys.